Our final presenter is Rob Furby, Head of Physical Healthcare Services at Rampton, which is a high secure hospital. Rob leads one of the largest physical healthcare services within the UK. With a background in critical care, education and medical technology, he moved to Rampton in 2019, leading on restructure of the service, which has been recognised as outstanding for areas in practice by the CQC. Rob is undertaking a PhD in the experience of patients within forensic settings at the end of life, seeking to close the inequality gap.
As I've already had a fantastic introduction, I won't go through it myself. However, I've just got some basic acknowledgements just to say huge thanks for inviting me, that they're not paying me or funding my mortgage, but they have paid me my travel expenses to get myself here. So what I'm going to be able to go through today is really an opportunity, quite a rare opportunity really, for people that have got no experience in forensic services at a high secure level, to be able to see over the walls at the levels of health inequality that patients with severe mental illness and offending history have, who are often seen as very bad people, but are often just very sad cases. We're going to look at our service. It's a nationally unique service. It's one of the, well, if not the largest one within the NHS, and how we're going to look at that in terms of the bigger picture nationally around how we deliver physical healthcare services within secure settings. I'm hopefully going to deliver you some information which I hope will fire you to help support to reduce the health inequalities that our patients face, whether that's clinically in your practice or whether that's in industry to support us with innovation and new technologies to decrease that health inequalities that these people face. I'll talk about our patients, our services, our staff, and how each individual clinician in themselves can help support to grow, to narrow these gaps that we face. We'll talk about the evidence of tissue viability in secure services, acknowledging that it's limited and often of poor quality. And then I'll look about how we've made a change over our last 5-year journey as our organisational change has grown and has developed. So who are we? Rampton Hospital is the largest high secure hospital in the UK. It serves a population of the entire of the United Kingdom, including Ireland and Scotland, for high security. We take referrals across the whole of the United Kingdom and including Europe. We offer 5 distinct care streams. So we've got national services for learning disabilities, which includes ASD. And we've got national services for women, including LD within the women's service. We have regional services for mental health and personality disorder, and we have the only profoundly deaf service where patients' primary point of communication is BSL in the entire world. As a service, we're a large one. We're about 50 strong within physical healthcare, and we're split across 2 distinct care pathways. So our primary healthcare pathway that looks to replicate the physical health that you would access as a general member of the public through primary care services. And then we have a 7-day, soon to be 24-hour urgent care service that delivers a model of a walk-in centre without walls. We have an average of around 1,500 patient contacts a month. So we've only got 270 odd patients in the hospital, but as a service, we have contacts with 1,500 a month. So as you can see, we're a very busy service. It's very dynamic, and we have to approach things in lots of different ways to support the mental health nurses to deliver the holistic physical and mental health care within our services. We are a huge MDT made up of multi-professional groups, medics, ACPs, AHPs, lots of administrators, general nurses and registered nursing associates. So the bigger picture then, nationally there's been so much work done around health inequality, and the picture of health inequality is moving. There's a large amount of funding around research, and there's lots of national bodies that try to help support us to narrow these health inequality gaps. However, it appears that we just seem to be pouring into a pot with a hole in the bottom of it, and it doesn't matter what we do, these gaps aren't closing. So we've seen the King's Fund and their work, we've seen the NC Pod report in how we're delivering physical health within mental health settings and the poor outcomes that our patients are facing. We've seen advice around mental health, nurses, clinical skills and how to deliver physical healthcare services. NICE have tried to support us, but as acknowledged by my colleagues this morning, we're doing it with less staff, less money and more patients. You know, the demand for high security beds is huge, the waiting lists are long, and we've got high incidences of harm while patients are on waiting lists. We cannot get the patients through. The demand is huge and the burnout within the teams is massive. And this is on a background of a huge amount of health inequality. So patients that have got a severe mental illness, whether this is within secure settings or without, will die 15 to 20 years sooner than patients without a diagnosis of a severe mental illness. So your diagnosis of bipolar, schizophrenia, first episode psychosis, chronic psychosis will automatically shorten your life. If that was a cancer diagnosis, the world would be up in arms about it. If it's a severe mental health diagnosis, people aren't really bothered, unless you're in it with us. 75% of the patients will die from preventable physical causes. People think people die with severe mental illness because they take their own life. They don't. They do take their own life, and it is a big cause of death, particularly with the younger population. But actually, these patients aren't dying 15 to 20 years before everybody else because they're taking their lives. They're doing it because of poor clinical outcomes in relation to their physical health. They will have much higher levels of obesity and diabetes. 60% of our population is diabetic. 65% of our population has a BMI above 30. You know, the incidences of these chronic conditions is massive within secure services. However, we're not very good at picking it up. Less than a third of patients will be screened for cardiovascular disease, despite their diagnosis of severe mental illness. And even if they're screened, nobody does anything about it. We're measuring the pig all the time and doing absolutely nothing to make it any bigger. You know, we're assessing, and what meaningful interventions are we putting in place to change outcomes? There's a higher burden of disease. They're three times more likely to attend A&E. They're three times more likely to smoke. And they're far more likely to have a skin breakdown, and it's going to take longer to heal if they do. Why? Well, the patients themselves are their own worst enemies often. They've come through a huge burden of trauma, adverse childhood experiences, and they've built walls against professionals. They've built walls against people. And they're now coming into contact, particularly within secure services, as a mandated thing. They're detained under the Mental Health Act. Our average length of stay is 7 years. They're detained under the Mental Health Act for a long period of time at high security. But they're put in front of people that they've built walls against because people have treated them poorly previously. And they've come with a huge burden of trauma and a huge burden of poor social determinants of health and a huge burden of experience. And they have got a severe mental illness, so they'll struggle with insight of actually, how do I invest today to see a reward in 10 years' time? If I said to you, you need to start going to the gym every single day because in 10 years' time, your reduction in heart disease might go down by 10%. If you're engaged, you'll go, yeah. If somebody said that to me, I'd be like, nah, I'm not going. But if I've got severe mental illness, I'm even less likely to do it. So if we're not going to invest in our 10-year, 20-year, 30-year health outcomes, how is somebody that has got no hope for tomorrow, for next week or the week after, going to do anything to invest in something that's in 10 years' time? They don't see themselves alive in 10 years' time. They're poor with their medication concordance. They lack to understand, and the polypharmacy is massive. These patients are on 2 and 3 and 4 drug cards, 20, 30, 40 tablets a day. You know, they're going, we can enforce the mental health medication. We struggle to really get support to enforce physical healthcare medication. So that's the first thing to go. As soon as you're going to try and put barriers and maladaptive coping strategies in your health, you're going to use your physical health to weaponise that and to take back the control that the people around you are trying to enforce on you. They're trying to take control of all elements of your life in high security. So the things that you've got to push back on that are things like your physical healthcare medication, you know, because actually they can't enforce that. They can give me my antipsychotics, but they can't give me my insulin. They've got poor activity levels. They've got poor, because of the lack of activity, the restrictive practice, the obesity and the poor outcomes, they've got a much higher burden of frailty. You know, we think frailty is an older person's disease. I've got patients in my care at the age of 30 that would have had a Rockwood score that's worse than patients in their 90s. And they're 30, they can't walk, they're having to use a wheelchair. You know, they can't get about their basic activities of daily living. You know, their frailty is really high, but they don't have we see because they're 30, oh, they can't be frail. They're malnourished, you know, they're massively obese, but they're desperately malnourished because what they're putting in their bodies is poor because they're using food as a maladaptive coping strategy. So as you can see, the patient is a complex entity, and this is where we need that joint working together between us, the mental health services, the psychologists. We need to be working to a common goal to find in all of our work that physical healthcare is built into that. And I think where we need to really focus is around health psychology. You know, we work around schema work to look at risk, to look at their trauma and their recovery, but we look at it from a mental health lens. We set them recovery goals for their mental health. We need to be setting them recovery goals for their physical healthcare too. And we need to understand how that psychological input can bring in physical healthcare as well. The system is the wall. The patients have their own internal walls, but the system in which they're being cared for, or not as the case may be, you know, is not built for joint up working. We all talk about joint up working. We need to join up working. When we join up working, we get better outcomes. When we join up working, we do this. The systems aren't built for join up working. The systems are built for isolated. We talk about specialists. You know, I'm a specialist in this and you're a specialist in that. You know, we cannot have specialists when we're talking about this fundamental care. We need to be collectively working towards. Most of the patients in our care don't really need specialist input from a physical healthcare perspective. They need a generalist input from a physical healthcare perspective with a point of escalation. So the buildings aren't made for people with disabilities. So the inability to make reasonable adjustments, you know, the systems are poor. Even within new builds, we were a mixture of estates that was built in 1909 and we've got a estate that was built in 2016. I would argue that some of the estate in 2016 is nearly as bad as the estate that was built 125 years ago. You know, with 125 years, we're still building buildings the same as we were 125 years ago. You know, and we're not building to this and an acknowledgement that the patient demographic is changing. You know, we've struggled with staffing levels. We can't make adjustments. We talk about restrictive practices that are often deconditioning in nature. We think about the mental health risk and the trauma associated with restrictive practice, but we don't think about the deconditioning. That person in long-term segregation, that person that's in and out of seclusion, that person that's utilising mechanical restraint, to be able to manage that mental health risk, there's no consideration about how that's deconditioning them and how we're making interventions to manage trauma and physical deconditioning at the same time. We've got massive variability within local and national services. You know, think about where you work now. If you needed to contact a tissue viability nurse, is that easy? If you needed to contact a diabetic nurse specialist, is that easy? You know, for me, I'm really lucky. We've got really strong links and we've got specialists coming in on a weekly and monthly basis to run clinics and help support us, but that's not available everywhere. You know, physical healthcare moves very rapidly. You know, you can read a nice guideline today and in 3 months' time it'll have been updated and you're supposed to be doing something completely different. So, and for mental health moves very slowly. You know, we're still treating people with antipsychotics that were designed in the 1950s. So how are clinicians that are used to a pace of change that's slowish supposed to keep up with a pace of change within physical healthcare that changes on a monthly basis? You look at COVID, how many rapid guidelines were submitted in COVID? They were coming out every other day. So if you are a clinician working in a space where development is slow, how are you going to keep up in an area where development is so rapid that even if you try to, you can never keep on top of it all? We lack specialist commissioning. I often get told, well, we don't get paid to come into forensics. Sorry? Just because there's a wall there doesn't mean our patients, if they had a postcode, if I took them out of and gave them the same geographical postcode in a house on the estate, you would come and see the patient. So why? Because they're in the hospital, they've got the same postcode as somebody you're visiting, so why is it any different? Why? Because they're in a secure setting, does that make it an impossibility for you to come in? The patient doesn't biologically change when they come through the door. They are the same person as they were out in the community. Our road routines, the disconnection from their family, from the community, the sense of loss, You know, how are we at the highest end of security preparing patients to transition to take responsibility for their health when we're taking all responsibility away from them? You know, and how do we manage that dichotomy within services where we're taking responsibility away to manage risk, but actually we're wanting them to take responsibility for their physical health? It's not concordant with each other. We lack IT connectivity systems. I struggle to get GP records. You know, I'm working blind when a patient's admitted to my service unless it happens they come from a service that uses System 1. I use System 1 in physical health, and my colleagues in the mental health wards use Rio. So we're using two completely different situations, and every time I type my notes, I have to copy and paste it for them to be able to see it. And I can't. and we're working on different systems. You know, community use a different system to what we do. The hospital uses a different system to what we do. So to get access to these things is really, really difficult. We aren't built to do conjoint working. So when we talk about working together, we are working against a system that's built to work in silos. And we have to be aware of that. You know, that does burn you out. You're thinking you're trying to fight against a system, and you're fighting against a system that respects silo working, respects specialism, and respects boundaries. And when you are working in mental health and trying to deliver holistic care across physical and mental health, you're working against those system structures. Us as clinicians, we enforce some of that. So I'm a general nurse. Oh, the proper nurses are here, don't worry. I think I'm no more a proper nurse than you are. We're on the same register. You know, you worked as hard for your PIN number as an LD or a mental health nurse as I did for my PIN number as a general nurse. I'm no better or worse or different than you. My skill set is different. And we talked earlier about, does nursing education need to change? It absolutely does. People do not come as an endocrinology problem, as a mental health problem, as a respiratory problem. So why do we nurse them in that way? We need to nurse holistically. And this is where our overseas colleagues are so phenomenal in this space, because they train generically as nurses and then specialise post-graduation. The same as medics, psychologists. Every other health profession that we work with trains generically and specialises postgraduately. Nursing trains speciality. And it enforces this model of that's mental health, that's physical health, that's learning disabilities, that's children. And people come together as holistic, as part of a family unit. And we're never going to nurse them in that way while ever we're segregated into speciality. Our scope of practices is different. People get worried about, well, that's not my job, I can't do that, I'm not a general nurse, you need to do that, you're a physical healthcare nurse. We look at competencies and training. We've heard already about the differences. How do we maintain that when we're not doing it very often? We're expected to have a wide scope of practice, but limited scope to practice. So I learned to suture. I might not do it for 3 months. So how do I maintain that clinical competency? I'm expected to be a wide scope of practice, but have limited scope to practice those skills. Our prescribing practices are different. We use some very dangerous drugs. You know, clozapine, lithium, high-dose antipsychotics are toxic substances. We give them out because they save lives from a mental health point of view, but they cause harm from a physical healthcare point of view. And we often don't manage that balance particularly well. We're pressured for time, and we've got a massive variation in our ability to apply restrictions. You know, we can care plan in high security for most things for patients. If you're working in rehabilitation, the patient's well within their right to go to Section 17 leave and buy 25,000 calories worth of Mars bars, come back to the ward and eat them all. So how are you going to manage their type 1 diabetes, their obesity, their cardiovascular disease and their hyperlipidemia when they're eating 25,000 calories worth of Mars bars a day? They're ordering takeaways. You know, the ability to apply restrictions and to educate holistically for patients is difficult. In terms of the evidence specifically around tissue viability, Medstrom is a health technology provider for surfaces and frames, and that's tissue viability is their bag. It's limited within secure settings. There's high rates of wounds, slow rates of healing, our limited knowledge within the working force. There's a need for education, and there's absolutely a need for close working links. You know, and that's repeated again and again. I did a lit review. There was about 17 papers. Some of them were reasonably good quality. This is the best of the quality that I could find, and the message was exactly the same. What are we doing to address the rates of wounds? What are we doing to address the slow rates of healing? You are not going to heal a wound if you are obese with cardiovascular disease, peripheral edema, high glucose levels, poor personal hygiene. You can put as many dressings on that wound as you like, it's not going to heal. So how are we treating people holistically within mental health settings, accepting that their behaviours impact the outcomes, and we're treating people holistically. So how are we making a change? The two pictures on there are a standard bedroom within high security. As you can see, it's all foam mica, it's all low ligature, and it's all fixed. So how, with somebody with a mobility issue that needs a wheelchair or needs pressure area care or a hoist, you're not going to be able to do it. You can't get the hoist in the room. You can't get a nurse on the other side of that bed. The bed doesn't come up. You know, the buildings are built for patient groups that were coming into secure settings in the 50s and 60s that were young, from prison, ability to mobilise, limited comorbidities. Our population in secure settings is not what it used to be. You know, the patients are getting older, they're getting more comorbid, they're getting frailer, and they're living with a much wider burden of physical illness. So our environments don't work. We need to think about how we can change those, and we need to put that into our planning and our strategic view. We need to look at promoting mobilisation, particularly where there's restrictive practice, and we need our AHPs to support us with that. Our physiotherapy and our OT colleagues are absolutely fundamental in this to support mobilisation. Mobilisation for me is the root of success. It helps so many things, and we don't put enough pressure on it to get it done within the settings. It involves positive risk-taking. Do we really need to use restrictive practices, and how are we care planning restrictive practices for deconditioning and the use of product? And we'll talk later around how we might be able to use those sorts of products. I'm no tissue viability nurse. However, for those that aren't particularly au fait with how pressure damage develops, you've got two routes to it. You've got pressure, so you've got a bone on a vessel which reduces blood supply. You've got tissue necrosis, and a pressure damage develops. It can be compounded by friction, where the skin and muscle goes in one way and the skeleton goes in another. And within secure settings, you see this time and time again. A lot of patients have got a very sedentary lifestyle. They spend most of the time on their backside or in bed, and we're seeing patients restrictive practice mechanicals that are using a lot of shear and a lot of friction. So we've got a high risk of pressure damage within secure settings. So what are we doing around that? So it's the same, you know, if we can get a patient to do it themselves, get them to do it themselves. It takes the pressure out, it takes the shear and friction out. We need assessment. You know, an assessment with action. There's no point ticking a sheet and filing a form. That doesn't change anything. You know, we need to assess, acknowledge, and refer and take action to be able to minimise this risk. We need to control moisture. We know personal hygiene within our patient cohort is poor. They need support with that. A lot of patients come to our services don't know how to shower properly. It's this kind of level of support that patients need to look at their healthcare more holistically. We need to look at mechanical restraint, how we're utilising it, how we're reviewing it, and how we design it, and things like frames and surfaces and the use of slide sheets and equipment that's available there, built into the frame and built into the core competency of staff. How we do this locally, so this is our logo. And these are our three strategic aims. We promote, we support, and we rescue. And that links to our overarching physical healthcare strategy as a hospital. So we promote good healthcare, and that's pulling multifactorial things to support patients, to improve their overall outcome, to minimise the risk of illness, and to optimise the quality of life. And our use of technology in that is fundamental. So a good frame and a good surface and a good slide sheet and good moving and handling will promote that patient's skin integrity. So that's just one example of how technology might be used. We support it. So we have a complex case nurse who works full-time to manage our most complex patients, to holistically pull our people together. And we track, we do rehabilitation. We've got rehabilitation physios, we've got MSK physios who support us with that. We look at co-production with patients. We go to our patients and say, we need to nurse you in mechanical restraint. These are the associated risks. How are you going to support us to minimise those risks? We look for the correct environment. There's a constant push for out of ground. You can't send the patient to secondary care. My take on that is the patient needs to be nursed in the right environment for them. Sometimes A&E is the right environment, and with the greatest respect to our A&E colleagues, sometimes A&E is not the right environment. It's highly traumatic, highly distressing, and it's not a place you want to be if you're in psychological crisis. So we need to think about what the correct environment is, think about ambulatory pathways, etc., training and education, and we need to grow our evidence base. We need to look at research around how we deliver physical health care and what models of care look like within secure settings to be able to improve the outcomes of patients, not just today, but in 10 and 20 years' time. And that's our primary healthcare function, and then we have our urgent care function that does all of these things. We're referral, we're triaging, we're responding to medical emergencies, we're seeing patients with minor injury, minor illness, suturing, minor surgery, and all of these interventions that we're doing. So our promote and support rescue overarching aims underpin all of the work that we do as a service. So in summary, our patients have a bloody tough deal. We have an audience for them while they're in our care. They probably won't get this opportunity to build those relationships, positive relationships for their physical health again. They'll go back to prison where it's constantly moving. They're ghosted from one prison to another. They're not in a situation or a setting very long. They don't know where they are. They don't know what tomorrow might bring. But they know how long they're going to be with us because they're being reviewed. So we can commit to them to say, look, you're with us for this period of time. What can we achieve in that time? If they're with us for a short period, it might not be as much as if they're with us for 20 years. You know, but they are a set audience and it's an ultimate opportunity. There are inherent and systemic disadvantages to that, but the barriers to good physical health are things that we can break down, but we have to do it mindfully and holistically. Education is key to that. Understanding where the challenges are gives you a good foundation to build up from. We need collaborative working, accepting that the system isn't built for that. We have a duty to advocate for our patients. You know, we are professionally accountable to advocate for our patients, and they are a lost voice. Particularly with forensic people, they're seen as bad people who don't deserve. Lock them up, throw away the key. They are sad people who have been through many different difficult things, and we need to be able to enhance that support to allow them to recover and recoup and return to society. It is overwhelming. You know, I've been in a period of burnout several times over the last 5 years thinking, I'm a one-man shop trying to change the world. It's hard, but we can do it because there are other people feeling the same way. We need networks, we need to communicate, and we need to share challenges and learning. And there isn't a right way of doing it. We don't have the evidence base to say this is the model of care. You know, you look at our colleagues in A&E, critical care, they've all got their national programmes of how a unit looks, how it runs, what the staffing is, what the night scan, you know, there's standard structured models of care for these things. There isn't within mental health services, and we need to address that. And we need support from industry and others with innovative thinking to look at what our inherent risks are and how we can engineer ourselves out of them. Thank you.